Welcome to Brain Ponderings, podcast with neuroscientists at the forefront of brain research. Today, my guest is Professor David Nutt. He's the Edmund Safra Professor of Neuropsychopharmacology and Director of the Neuropsychopharmacology Unit in the Division of Brain Sciences at Imperial College London. He has a storied career studying effects of drugs on the brain, both from basic research in animal models, translational work, and numerous, too many to catalog, I guess, clinical trials. So he probably knows more about how drugs affect the brain than anybody in the world. So welcome, David.
Well, that's very kind of you. Nice to be with you.
And we'll get into, we'll talk a little bit about your research before you get into the, you and others, and I'm not a neuropsychopharmacologist, but I'm aware of this. There's a disconnect between what's known about the science of how drugs affect the brain and governmental policies on that, and we'll get into that later. But and actually, you founded this drug science. Well, it's a website, a source of information on science, and you also have your own podcast. Drug science podcast.
Yep.
And so you started in basic research. Looking back, I went on PubMed, and as we do, right, and look back at, go to the bottom.
Exactly.
And so you started looking at in animal models of epilepsy, if I read it correctly, looking at the effects of different drugs on that. Yes. You got interested in the major inhibitory neurotransmitter in the brain, GABA.
Yep.
And because, well, seizures involve hyperexcitability and GABA, but can you talk a little bit about your trajectory, which I think is a good trajectory. It's my trajectory, starting with the basic and then moving up to humans.
Well, I knew that I wanted to be a scientist when I was very young, like 8 or 9. And then I became clear I wanted to be a brain scientist, probably when I was about 16, 17. And I actually applied to university to do physiology. But then I realized that I was really mostly interested in human brains. Okay. So I changed from physiology to medicine. And but I always wanted to understand the basic principles of the brain. And obviously, it's much easier to do that if you're working with animal models than with humans. So I was really fortunate. I got a chance to do my PhD for nearly 4 years with a guy called David Graham Smith in the MRC Clinical Pharmacology Unit in Oxford. He was really grateful to have a psychiatrist interested in doing science. And I started working on the GABA system. But what a lot of people don't know is that actually when I was an undergraduate, I was at Cambridge, and my tutor, very fortuitously, my tutor at my college, Downing, was a man called Jimmy Mitchell. And he was one of the people that discovered GABA, or at least he discovered that GABA was an inhibitory neurotransmitter. So I kind of and I was, again, fortunate. I was, 18, and I was in dialogue on a regular basis with people that were understanding the nature of synaptic transmission, which was still just beginning to be accepted. Up to that point, of course, there was a sense in which the brain was a series of electrical connections rather than chemical ones. So I learned about GABA from a very early age. I went to do my PhD. I was interested in how the brain was controlled. And I didn't start working specifically on epilepsy. I worked on seizures because what I wanted to do, I wanted to see if I could understand why ECT worked. And I wanted to see if I could produce other kinds of seizures that would be as good as ECT. And in fact, there's no question in animal models, if you block GABA with a drug like bicuculline or pentylene tetrazole, you get seizures, and they produce the same behavioral changes, the same augmentation, for instance, of dopamine function in the brain as ECT. And then, of course, I rolled on to understand more about GABA, and the benzodiazepines came along, and then we began to explore the relationship of the benzo receptor to the GABA receptor, and then into areas like tolerance and dependence and withdrawal and that.
So that's pretty interesting. You were interested in seizures from the standpoint of, a treatment for depression that's resistant to drugs, electroconvulsive therapy.
Exactly.
And this is something people need to know. Your nerve cells are firing a lot. And when they fire, not only do things happen, they control behaviors quickly, but good things happen in terms of structure and synaptic plasticity and the plasticity of the brain, this activity dependence of plasticity.
Yes, yes. Well, of course, you and I have both been, we've both grown up in this remarkable discovery of long-term plasticity. I mean, learning, it's been a revolution, hasn't it? And of course, GABA has a role there. It's GABA. In fact, LTP exists because GABA eventually tolerates out so that the glutamate system can take over and lay down a memory.
Yeah, the system has to reset. It's important. Well, I don't need to go into learning and memory a lot in this talk, but essentially,
Okay.
If you see something and hear something for the first time, then you get inputs through those two different sensory systems, vision and hearing. And the circuits converge on certain neurons, probably in the hippocampus, and that simultaneous activation leads to the structural change. It's fascinating stuff.
Yeah. And
Now,
that's so critical. I mean, plasticity and structural change. We didn't, when I started in whenever it was, 1979, doing research, I think we thought the brain was about continuing to run software. Now we realize there's a hardware change as well, which is obviously, I suppose, necessary. We should have thought that. We should have realized it was too difficult to just do it with software.
Yeah, and the key thing is calcium influx into the neuron. And it's been known way before neuroscience knew this, that calcium affects the structure of cells, the motility, the cytoskeleton. So maybe it's not too surprising. Okay, so then GABA. So GABA is very, very interesting. First drugs, well, I think, for sure. First drugs used for anxiety disorders or so on activate those inhibitory receptors, right?
That's right. The benzos are barbiturates and all that. Yeah.
Yeah. And you have a drug development program around GABA, is that right?
A drink development program.
A drink
development program. That's right. So one of the things I discovered during my PhD was if you get a rat very intoxicated, so it's falling over with alcohol, and then you block GABA A receptors, it sobers the rat up rather fast. And I've always been fascinated by alcohol because of the fact it's so popular as a drug, yet it's so harmful as a drug. And over the years, it's occurred to me that I've spent a lot of time trying to find antidotes to alcohol. I've tried to find anti-craving agents, trying to find treatments for withdrawal, etc. And about 20 years ago now, I realized that alcohol was such a complex molecule and so many different effects on the body. You couldn't get antidotes to all the effects of alcohol. So I then began to think, well, could we replace it? And I started working on the concept that the first impact of alcohol on the brain is to enhance GABA function. And so I began to look for molecules which would gently augment GABA in a way that alcohol does. And I've made some molecules that do that. And I'm in the process now of trying to get funding to take them through food safety testing. So at some point we can allow companies to put them into drinks as an alternative to ethanol.
Yeah, that's really fascinating thing. So yeah, alcohol, I've when I remember when I was in high school, a friend of mine, he'd gotten his driver's license a couple of years. He was 17, so he had his driver's license for a year. And this is up in rural Minnesota, and all the roads are 2-lane. And he got hit and killed by a drunk driver. One of my friends. So from an early age, I came to appreciate that as a problem. And then I also have a relative who has this, it's a strange thing. So she'll go like alcohol free for a month. Then she'll go on a binge. She'll consume so much alcohol that she passes out and she has to be taken to the hospital. It's a terrible thing.
Yeah, absolutely. And it's well, there are many different ways in which people get damaged from alcohol. I think in the States, I think you've passed the 1 million person mark dying on the roads from alcohol related. That's a lot of people. It was one of the reasons why in America you put the drinking age up from 18 to 21 to reduce, and it was successful, to reduce the number of kids under 17, 18, 19 who were dying in road accidents.
Yeah, and it was bad when it was 18 because that's the age when kids go to college. And so you have a kid, maybe they didn't drink at all in high school, but then they go to college and there's other people drinking and they get,
and they die, and they die.
Yeah. Okay, and so you were at the NIH for a while too, right?
Yeah, I was in NIH 86, 88. I came over from Britain to run the inpatient research ward and to focus on, there were fundamental questions, like what's alcohol dependence due to, and how we can take people who are abstinent and how we can keep them abstinent. And yeah, I spent 2 really happy years there. In fact, I probably would have stayed in America if Americans played cricket. But when I saw my son playing baseball, I thought, no, he's got to hold the bat upright. Hang on, let me just kill this. There's a message coming through. It's gone. Okay. So yeah, no, I enjoyed I had 2 wonderful years at NIH. It was in Building 10, working in the Alcohol Institute with Michael Nutt. Learned an awful lot. It was an exciting time.
I think Building 10 is one of the biggest buildings in the country, maybe the biggest.
They said it was. They said it was the biggest brick building in the world, I think. And then I think some Romanian dictator, a bigger one. But it was an amazing build because, I mean, the intellect in that building was just, it was amazing. Every day there were 3 or 4 lectures. You could spend your whole life just listening to visiting scientists.
Yeah, you can. That can actually be a problem, can it? Because you have to manage your time really well when you have a big lab and doing a lot of studies.
Yes.
Okay, so that was at the National Institute, NIAAA, we call it.
Yes.
Institute on Alcoholism and Alcohol Abuse or something like that. Alcohol and alcohol abuse.
That's right. That's the one. Yeah.
But then there's another institute at NIH that's the National Institute on Drug Abuse, NIDA.
Yes, that's
and
right.
When you're scientists like I was at NIH, they're very careful about what comes out to the public.
Yes.
And they're very maybe overly cautious. And you can get it, this is something I think has troubled you a lot, that for example, with marijuana or psychedelics,
Yes.
They're unwilling to put out any statements other than, these are, well, marijuana is becoming legal now, which I think is good for many
It
people.
was worse than putting out, they wouldn't even fund any research that might show that cannabis or psychedelics were useful. You could only get research funding to find evidence of harm to justify the illegality of these drugs.
Yeah, and so when did you get, you were an advisor for government agencies there in the UK. and sitting on panels of other scientists and then administrators, government administrators. And so what happened that you want, you outspoken? I think a lot of people throughout the world are appreciative of you speaking out and telling what the science says and how that should be used to make policy.
Yeah, thank you. Yeah, I started working for the government fairly soon. When I left NIH, I went back to Britain, to the University of Bristol, and soon after that, we started having deaths from ecstasy. So, because I knew a bit about the brain and a bit about pharmacology, I was called onto the committee to try to work out how we might reduce people dying from ecstasy deaths. And we took evidence, and we realized that the deaths that were occurring were largely occurring as a result of people overheating and dehydrating. And we discovered that what was happening in clubs was that they basically, the club owners were turning off the taps. They'd even turn off the toilets to stop people getting water. So they had to buy drink. And so then, and of course, a lot of the kids couldn't afford it. So they would dance all night and then die of hypothermia. So we actually changed the law. We changed, and the law still exists today. If you go into any bar or pub or club in Britain, you can always get tap water. We made that law fascinating. And we also encouraged, we couldn't make it a law, we encouraged chill out rooms. And those two small changes virtually eliminated deaths from ecstasy in our country for about 20 years.
That's fantastic.
Yeah, well, that was classic, that one of the very few examples of a policy that was logical, sensible, and worked. And then, so they asked me to then come on the committee to look at all drugs, and I said yes, I'll do that, but I just need to, we just need to know that we will look at all drugs in the same way as we looked at ecstasy. We will look at the harms and we'll work out how to reduce the harms. And they said okay. So I came on and I set up a way of assessing a 9-point scale of harms. And over about 5 years, we did all the drugs that were illegal. And of course, by the end of that, it was pretty clear that there was a big disparity between some of them and the other ones. So, and also, they didn't like us doing this, but I insisted we did alcohol and tobacco in parallel.
Yeah.
And of course, it turns out that alcohol and tobacco were more harmful than drugs like ecstasy and magic mushrooms. And the government really did not like that. And they really put a lot of pressure on us to justify these drugs staying illegal. And I couldn't do that. I couldn't deny the science. And eventually they sacked me. And then it created an enormous kerfuffle. And, for years I've, been arguing the case. And it was a big mistake, actually, to sack me because the public then wanted to know why.
Yeah.
And that was, that really encouraged a debate about drugs and drug harms, which has actually begun to move the dial now. People are much more knowledgeable about the comparative harms of drugs than they were 20 odd years ago.
Okay, so drugs can have, harmful effects on an individual and harmful effects on society as a whole.
Yeah,
so
that's right.
What's your kind of, I guess, just kind of talk about some ranking of,
yes.
So alcohol and opioids are clearly.
They're at the top.
Yeah.
And they're at the top. I mean, alcohol actually in our study, and then it's been replicated in Europe, it's been replicated in Australia, and only last year replicated in New Zealand. And in all those 4 Western jurisdictions, alcohol comes out as the most harmful drug overall because of the vast public use. So the way we did this was we looked at every harm a drug could produce. And it turns out there are 16 harms. There are 9 harms to the user and 7 harms to society. And then you ranked all the drugs on those 16 criteria and amalgamate them all. And alcohol is number 1 because the social harms, the harms to other people, are very high, and the cost to health, the cost of policing. Alcohol is not the most harmful drug to the user. That used to be in the old days. That used to be crack cocaine and crystal meth. Now it's changing. It's changing to fentanyls.
Yeah.
But so you can, and that actually, tells you that the scales is sensitive. But those drugs, thankfully, are not as widely used as alcohol. So overall, alcohol is the most harmful, followed by the strong opiates and crack cocaine and crystal meth.
Yeah.
And then at the other end, you've got things like magic mushrooms, LSD, MDMA, cat, really relatively, much less, much lower in harms than the other ones.
And nicotine, well, tobacco.
Tobacco in the middle.
Yeah.
Nicotine, interestingly, is quite low if you just have pure nicotine.
By itself.
Yeah.
Yeah. Yeah. The main harm to your lungs from smoke and your cardiovascular system.
That's right. And the cancers, the cancers, and that's from the tar and the carbon monoxide in smoking. Yeah.
Yeah. Okay, so why don't we go through the drugs a little bit and get into some of the pharmacology?
Sure.
Oh, you didn't mention cannabis, did you?
No, cannabis came in the middle. Cannabis,
middle.
slightly lower than tobacco in terms of overall harm, largely because you don't seem to get the cancer and the cardiovascular problems with cannabis that you get from tobacco.
Okay, so with cannabis, there's a number of chemicals in there, right?
Yeah.
The one that's most psychoactive is the THC.
Mm-hmm.
And how is it acting?
Well, it's acting on, this is the amazing thing. Your brain is stuffed full of receptors for THC. And of course, no one expected that. I mean, honestly, I think we thought, well, cannabis is a kind of like a big soapy molecule, it'll just dissolve in the membranes. But it turned out that there were receptors there, and cannabis THC binds to these. There's two cannabis receptors. There's one in the brain called the CB1 receptor, and there's one in the periphery in the immune system called the CB2 receptor, and THC binds to both of them.
Yeah, and the interesting thing, so back in the day, you mentioned opioids, right? So we have endogenous endorphins and enkephalins. So it's similar with THC. There are endogenous called endocannabinoids, right? So these receptors, it's not just they're sitting there waiting for some drug you take they're doing things all the time that keep our brains functioning properly.
Yes, and of course, but the cannabis was the endocannabinoids they're quite different from other neurotransmitters though, because they're made on demand. But when a glutamate neuron fires, glutamate receptors are activated, then breaks down or allows enzymes to turn some of the fats in the cell membrane into endocannabinoids, and then they feed back to the presynaptic neuron. There's a kind of homeostatic loop. We call it an adaptogen. It helps regulate and stabilize neuronal function. It's a really sophisticated system, rather different from the other neurotransmitters.
Yeah, because it's a lipid rather than an amino acid or derivative thereof. Yeah,
that's correct.
Yeah, and of course the membrane is lipophilic, right?
Yep.
And receptors are in the membrane, CB1 receptor. So, and THC is lipophilic too, right?
Yes, it is very lipophilic. Yeah.
Yeah. So is it getting in the membrane and acting? It must be within the membrane.
Well, no. Well, it's interesting. No, well, yes and no, because the CB1 receptor is definitely a G protein link. So I think the it spans the membrane, but I think the binding site. Actually, I don't even know. I don't know if we know where the binding site is yet, but it probably is going to be somewhere on the outside, but near the fatty bit as it begins to go into the lipid bilayer, I suspect. But I don't know. I haven't seen the molecular structure of that. That might be quite a hard receptor to get crystal structure. But I don't know the answer to that. So
Yeah. And alcohol is also lipophilic, right?
well, you see, that's been one of the great changes in the way we think about what alcohol does and what anesthetics do. So when I started in 1969, the idea was that alcohol was a kind of anesthetic. It got into membranes and dissolved in membranes and then messed up membrane function. So the brain was less active and therefore you went asleep or went into anesthesia. And about 20 in the early 80s, the concept began to develop that alcohol and other anesthetics did have binding sites on proteins as well. And it turns out that they probably are the most important for the primary effects of alcohol. It binds to the GABA receptor. It binds to some enzymes inside neurons. One of the interesting things about one of my theories I'll share with you about alcohol is why would a drug which is really quite toxic and kills 3 million people a year over time, why would a drug that toxic still be widely used? And the answer is because it's liked and it makes people happy and it's great for parties. But the other thing is, if you drink a lot, you vomit, which is so that's exactly the opposite of opiates. You take a lot of opiates, you just die. You take a lot of alcohol, you vomit. Why do you vomit? It turns out you vomit because alcohol stimulates a serotonin receptor, a 5-HT3 receptor on the vagus nerve in the stomach and makes you vomit. So that's a protective mechanism. As long as you don't inhale the vomit, as long as you're relying on your recovery position and you vomit it out, then that you clear the alcohol from your system, so you stay alive. And I wonder if that's one of the reasons. Alcohol is a very clever drug. It gets used a lot, but it doesn't kill quite as many of the people who use it as perhaps you might expect.
Yeah, I've been interested in a lot of natural products, things in fruits and vegetables, and their potential health benefits. And most of the things that are good for our health have a very bitter taste. And if we eat too much of them, in some cases, we'll vomit. So I think during evolution, there's multiple ways that we were protected from
Yeah.
dying from consuming too much of something.
Yeah. Yeah. Well, that's interesting, isn't it? Yeah. I mean, a lot of medicines are also very bitter. I mean, if you accidentally bite into a capsule of something, you'll discover how horrible it is.
Yeah. Yeah. And okay, so let's go to opioids next. What's their pharmacology?
Yeah, well, you've already mentioned the fact we have in the body these endogenous opioids, the endorphins, and this is one of the great stories, one of the great. I'll come back to that. I'll come back. I'll start that again. All right. You're going to edit this, I guess. Yes.
No, I don't edit. It's freewheeling. Just go ahead. That's okay.
Oh, you don't mind having that in?
You got an email, right?
Yeah. Well, no, that was a phone call. That was a WhatsApp.
Okay.
I don't know how to turn off your WhatsApp. Anyway, yeah. What was I going to? So, yeah. One of the great discoveries was when people discovered these natural peptides, which are opioid-like. Then there was a massive research saying, well, hang on a second. If these things are floating around in the brain, deadening pain, they must be working on something. There must be receptors. And that led to the hunt down for the opiate receptor. And it turns out there are at least 3 subtypes of opiate receptors in the brain. The mu, the kappa, and the delta. And the mu is the one that drugs like heroin and fentanyl work on to get people high, but also to stop them breathing. The mu receptor dampens down pain, but if you take too much of it, it stops you breathing. And then the other opiate receptors have rather different effects. That there aren't many medicines that work on the others. People are still looking at that though. But it's the mu that is both the good and the bad. Great if you're in pain, but not good if you take too much and stop breathing.
Okay, then psychedelics. talk about the history here. Many viewers and listeners may know a little bit about it, but you know, the history of, say, LSD and
Yeah, sure. Well, psychedelics, I mean, psychedelics, most of them come from natural products, or the all the original psychedelics like mescaline and DMT and psilocybin, they all come from plants or fungi. And then we have the modern ones, which like LSD, which is actually a semi-synthetic. It's a derivative of a lysergide that comes from ergot. And humans have met psychedelics since they became human. You know, humans would eat mushrooms and they would have found magic mushrooms, and they started hallucinating, and then they started drawing pictures of people covered in mushrooms. And in Latin America, South America, they've discovered how to get DMT, drinkable DMT in the form of ayahuasca, and then began to see serpents and jaguars. So ancient Greeks used to use a combination of ergot and alcohol, wine, to celebrate their what they call their Eleusinian mysteries, their magical excursions into another life. So psychedelics humans have used psychedelics forever. But the real breakthrough came, I think, really with Albert Hofmann making this extraordinary potent psychedelic called LSD, which transformed medicine and psychiatry in particular, because for the first time, psychiatrists had tools to change people's minds and improve people's mental health. But unfortunately, it got out into public use, and it changed a lot of other things. It changed art, it changed music, changed politics, was associated with the anti-Vietnam War movement, and it got banned just because the American government was frightened that LSD was actually going to encourage people to vote against war. And then when the Americans banned it, basically because you guys controlled the United Nations, the United Nations banned it, and it got banned in pretty much every country in the world. And that set back research by 50 years. In fact, it's still illegal. LSD is still illegal in every country in the world.
Yeah.
Still, I think except North Korea, but I don't think they do a lot of research on it there.
And LSD, my understanding, it's pretty easy to synthesize and would be very inexpensive to produce. And yet the research, so I'm wondering, you know, a lot of the clinical trials going on now are not with LSD, they're with psilocybin.
Yeah, well, we use psilocybin a lot. I'll tell you why. It's easier to work with. We've done LSD studies. We did the first brain imaging study with LSD. But the problem is the trip is 14, 16 hours long, which means if you're treating patients, they have to stay in hospital overnight. Whereas psilocybin, you can have a trip which is sort of 4 to 5 hours. So it means, I'm sorry, which means you can actually do a whole treatment program in the space of a day. And of course, if you use something like DMT or 5-methoxy DMT, the old toad scrapings, that can be a much shorter trip, less than an hour. So that means you can actually sort of work through the whole process much quicker. So LSD may be the most powerful. It's certainly the most potent, but it's harder to use because of that long duration of action.
I see. And that it doesn't matter if you lower the dose, it's still a long duration. If the person has a trip, it's going to be a long duration.
Yeah, exactly. I mean, we know why that is, by the way. That's been recently discovered by when the crystal structure of the receptor has been discovered, and it turns out that there's something so these drugs all bind to the 5-HT2A receptor. Mm-hmm. And that's a G protein coupled receptor, but the binding pocket has a flap. And when LSD goes into the binding pocket, the flap gets closed, so the LSD can't get out. So it's like a semi-covalent bond. Now, you don't see that with the other psychedelics, but LSD, because it's a bigger molecule than the others, seems to lock itself in.
Oh, that's I didn't know that. And okay, so these 5-HT2A receptors. So what a lot of people here if I ask people to name a neurotransmitter, they'll often say dopamine or
Yeah.
serotonin.
Yeah.
And because there's drugs that affect either receptors for those or
Yep.
the amount that's in the synapse. But the thing that's often not appreciated so much is where those receptors are. And, you know, glutamatergic neurons make up 90% of the neurons in the
Yep.
brain.
Yep. Yeah.
And the circuitry throughout the brain, it's mainly glutamatergic neurons. They can project between brain regions and so on. So all the kind of critical connections between brain regions are neurons that use the excitatory transmitter glutamate. So the psychedelic trip somehow, in my mind, has to involve changes in certain glutamatergic circuits.
Yes, correct. But what's really interesting, what is really uniquely fascinating about the 5-HT2A receptor is that it is most highly expressed in the most recently evolved parts of the human brain. And this part of the brain we call the transmodal cortex. It's the part of the brain which is way bigger in humans than any other primate. It's the part of the brain that does all the connections between our different brain regions. It pulls together all the high level thinking, planning, insights, creativity, language structure that make humans special. And it's loaded with these 2A receptors. There's almost none of them in the midbrain and brainstem, which is why these drugs are very safe, because they don't affect breathing centers or cardiovascular centers. And there's not so many of them in the visual cortex and not so many in the sensory motor cortex. So you can still walk around and actually see things. You see things a bit differently, but you're not blind. But they really concentrated in the parts of the brain where you do your thinking and pulling it all together. And that is why they're so powerful, because they change the fundamental organization of the parts of the brain in which you essentially have downloaded all your concepts, your prejudices, your memories, your beliefs, etc. And these can be changed temporarily by psychedelics, and afterwards some of those changes can persist.
And so the prefrontal cortex is right a main region of action. Okay, so then what about if you give a rat or a mouse a psychedelic? Is there any behavioral change?
You get a head twitch.
A head twitch. Okay. Okay.
That's how that is literally the head twitch is the bioassay for a psychedelic effect in a mouse and a rat. And that is a problem, because there's a lot of research going on. A lot of people are concerned about the psychedelic state. And one group of people in particular are very concerned, and that's the military. Because in the military, there are an awful lot of veterans who've been damaged by war.
Yeah.
And they've got PTSD, and they would like to have treatments. But currently, if you're a vet and getting a vet pension in America, and you use an illegal drug like psilocybin to get better, and it's found out, you could lose your pension, and that can have a really deleterious effect in your life. So what the veterinary medicine want are to have psychedelic drugs that are legal. Now, generally, the position has been by the FDA and the DEA have generally said any new psychedelic by default will be illegal. So companies are looking at finding drugs which have the neuroplasticity effect of the psychedelics, but which will stay legal. So they're looking for what we call non-psychedelic plastogens. And the way they seek these is to find substances which increase synaptic growth and dendritic growth in animals, but don't cause a head twitch. Now, they found plenty of those, but of course, it may be that not twitching, just because it doesn't cause a rat to head twitch, that doesn't mean it's not going to be psychedelic in humans. So we're actually in a very interesting time because it won't be long before those new compounds go into humans, and then we'll find out whether the rat is a good model for the human or not.
Yeah, but it's things are kind of ass backwards, right? I mean, the psilocybin and DMT, even LSD,
Absolutely.
they're safe. That people don't die from taking these.
No, exactly. They should never have been made. When I give this lecture, and I always say LSD was the first drug and maybe the only drug to be banned because it changed the way people voted. They voted against the war. And then the other psychedelics got sucked in because people said, well, you know, if we ban LSD and people just take mushrooms, so let's ban every psychedelic. And so any psychedelic that was remotely like LSD got banned.
Okay, and even before they were banned, there had been some research done already suggesting that they may have some clinical benefit.
Oh, yeah, there were 1,000 clinical papers published, 40,000 patients. Yeah, no, absolutely. Lots of data suggesting that they were safe and they were effective in reducing depression, anxiety, alcoholism.
Yeah. But things are looking up, right? So they're now the government agencies are, as far as research goes, anyway, more lax, maybe even excited somewhat about funding.
Well, let's put it this way. There's definitely a more open-minded approach. They're still illegal,
Yeah.
but something radical happened last year. For the first time in 50 years, NIDA funded a study of a psychedelic. It funded a study of psilocybin in the treatment of tobacco dependence. And that's so important because tobacco is the biggest killer in the world. It kills more than COVID. So that's a sea change. NIDA has accepted that there's a huge potential. And NIH, I think, will probably start funding some trials in depression. But in America, what's happened is there's been two things have happened. There's been a lot of companies set up to work with psychedelics now because they see them as a major breakthrough in mental health treatment. And there's very little else on the horizon in mental illness.
Right.
And also a lot of philanthropists. There are a lot of rich people in America who got rich because they took LSD once or twice. People like Steve Jobs, you know, a single LSD trip contributed to him making the biggest company I think the world has ever known, because it made him see that you could actually bring together something that was beautiful and something that was very functional, had good engineering, and the concept behind the apple and that was just brilliant. And he says, you know, LSD was part of that. So, and those rich people have given quite a lot of money to American universities as philanthropic donations. So there is a parallel track of donor money that's giving a big boost to psychedelic research in the States.
Yeah. And think of all the people in the last 50 years have great potential in their life and suffered from depression or an anxiety disorder or PTSD to the extent that, you know, they couldn't function well. And think of all that.
It's terrible.
Potential lost.
I think it's the worst censorship of research and health in the history of the world. I mean, just a back of the envelope calculation, right? So a lot of people don't know this, so I'll share this with you. The founder of Alcoholics Anonymous, Bill Wilson, was a Yale undergraduate, and he started drinking at 18. And at 33, he was going through one of his many withdrawals. And there was talk of locking him up in what they call a hospital for chronic inebriates. And in his detoxification, in his withdrawal, they gave him a new treatment, which was called the belladonna cure, a scopolamine, a cholinergic blocker. And that's commonly used in Latin America, South America. The plant's called datura, and it's commonly used to produce hallucinations and a psychedelic state. And he had a profound experience. He said it was like being on a mountain and a wind, not of air, but of spirit was blowing. And it blew through him. And he said, it sort of freed me. I burst upon me. I was a free man. I was free from the shackles of my alcoholism. And then he set up Alcoholics Anonymous. And then in the 1950s, when LSD came along, he took it and he realized that LSD could do this in a much more predictable way what scopolamine, belladonna had done. And he got support because he was so famous then, and Alcoholics Anonymous was so powerful. He encouraged the US government. They did 6 trials of a single dose of LSD in the treatment of alcoholism. And 10 years ago, 2 Norwegians went back and got the source data, and they did a meta-analysis. They showed that 1 dose of LSD had an effect size about 3 times that of the best treatments we have today for alcoholism. Now, on the back of my envelope, in those last 55 years since it's been illegal, I reckon at least 100 million people worldwide have died prematurely from alcohol. Now, suppose LSD had helped 10% of them. Might have done more, but let's say conservatively 10%. So that's 10 million lives saved. How many lives have been saved by the ban on LSD? Well, probably none, because it probably didn't affect recreational use at all. Maybe 1,000. Even if you say 1 million, the equation is so stacked in favor of having it as a medicine that it is, as I say, the worst censorship of research ever. And it was purely political. It was about the Vietnam War. They couldn't ban anti-Vietnam War protests, but they could ban the people that had the signs saying drop acid, not bombs.
Yeah, I remember those times. I was how old was I? Yeah, I was in my early teens then. Yeah. And those protests had an effect, though, as in terms of so you mentioned the drinking age, right? It was 18 and 21. Back then, the voting age was 21, and the age for enlistment or drafting into the military was 18. So these kids who didn't even have the right to vote having to go fight in a war.
Disgusting.
It's terrible. And
the other thing is, that the war eventually stopped.
Yeah.
But the ban on psychedelics didn't.
Yeah, that's right.
In fact, they just dug down and carried on telling the lies and created and funded so much research trying to justify the ban. I mean, I don't know. Did you ever follow the story about the monkeys on MDMA?
No.
So MDMA wasn't banned in 1970 with the psychedelic because it hadn't been invented then, really. But when it became popular in the 80s, again, there was an enormous moral outrage. People are taking this drug called ecstasy and having fun. Wow, we got to ban it. But you can't ban a drug simply, well, not really. You shouldn't ban a drug just because people are using it. So they had to create some evidence of harm. And there were, as I mentioned earlier on, as I was talking to you, some kids were dying of hyperthermia. Now, that wasn't justification for banning the drug, but anyway, it got banned. But people said, well, come on, now, we know how to stop kids dying of hyperthermia. Why is the drug banned? And they hunted around to try to find evidence of brain damage. Yeah. And there was a famous study that was done, and I remember it being published. It was published in Science, and the front cover of Science, as you know, there was a picture of a damaged monkey's brain following MDMA. And they said, basically, if you take MDMA, give it to monkeys in the same way as people take MDMA, they go into a club and they dance all night with loud music, the monkey's brain, particularly the striatum, is damaged. And we all thought, well, hang on a sec. We're not seeing a lot of people coming out of clubs with Parkinsonism, are we? And we said, this has got to be wrong. And in fact, it was rejected, but there was a lot of political pressure because Science is a magazine that essentially is published by the American Academy of Science, and that's a government-funded agency. So they published this paper, even though the referees said it was probably wrong. But there was still a lot of clamor. Scientists said, look, what's going on here? This doesn't make sense. And then they went back and checked what they'd done, and they'd accidentally given the monkeys the wrong drug.
They give
They'd
it
given
MPTP or something?
Oh no, it wasn't quite as bad as that. They'd actually given them crystal meth, which is between 10 to 15 times more potent. So they'd given them a gram or so of crystal meth each, and they'd had damaged their dopamine system.
Yeah, I
So that,
know one of my friends. So the NIA and NIDA intramural research programs are now on Johns Hopkins Bayview campus, right? And so one of my friends at NIDA is Jean-Luc Cadet. You may know him. He's
yeah,
done a lot of work on, and yeah, methamphetamine does do bad things to the
it
brain.
does. Absolutely. Yeah, that's right.
And then the story of ketamine, we haven't mentioned ketamine, so why don't you talk about that? Because I think it's been, in general, a good thing.
Yes, I do. I do think very much so. So, of course, ketamine is an anesthetic, it's an NMDA receptor antagonist. It was developed as a safer, more predictable anesthetic than PCP. And it was called the buddy drug. It was used in Vietnam. You'd carry it, you'd have it in your little pouch. You'd have a ketamine injection and some morphine injections to give it to people who've been severely injured on the battlefield. It's a particularly safe. It's the safest anesthetic, really, because it doesn't suppress respiration. So you can use it in the battlefield. You can use it in poor countries. Half of all the operations in sub-Saharan Africa are done with ketamine. You don't need a doctor. They can be done by trained nurses or technicians because it's so safe. It's used in children for the same reason. So for a long time, it was a standard anesthetic. But there was a bit of evidence of abuse, and people started to use it. And if you abuse it, you get tolerance quite fast. So you need to keep on pushing the dose up and taking higher and higher doses to get an effect. And that then leads to a problem, which is called the K cramps. And the K cramps are spasms in your bladder, probably due to crystals of ketamine. And then eventually your bladder becomes damaged. And then because of that, and also it can encourage people to do slightly dangerous things, like, going outside and lying on the floor watching the stars when it's -20 in Minnesota and they freeze to death. So there are deaths associated with ketamine. People go into the bath and float in the bath and drown. So ketamine got made illegal in around about the turn of the century to try to reduce these harms. But at that time, a group in Yale, John Crystal's group, were trying to model psychosis, and they tried psilocybin, THC, and ketamine, and they found the three of them, each of them could produce some, in normal healthy people, some measures which were like psychosis. But they noticed, and this was wonderful serendipity, they noticed that after the ketamine, the healthy volunteers got, some of them got a little bit happy and cheerful, a bit, like they was having an antidepressant effect. And they said, well, maybe it is an antidepressant. And they went on and did studies, and it was an antidepressant. And there was a massive number of academic studies and then eventually it started being used off-label as a treatment for resistant depression. And then a company called Johnson & Johnson came along and took the active enantiomer, the S-ketamine, and then they made that into a medicine as a spray. It goes up the nose, so you don't have to inject it. Most ketamine was given intravenously or intramuscularly, but now we have a spray, which is easier to use in a psychiatric clinic. And it does seem to be very helpful. It gets people out of depression when, say, the SSRIs haven't worked.
The only thing is with that, so I guess they have intellectual property on that route and method of administration, and then all of a sudden the price becomes very high when you have a drug that should be very inexpensive.
Well, yes, the racemic ketamine, anesthetic ketamine, is cheap as chips because it's, nearly 40 years old now.
Yeah.
It's off license, yeah.
And is it known? So a lot of antidepressants at the beginning of this conversation talked about electroconvulsive shock therapy, and a lot of antidepressant things, whether it's serotonin, norepinephrine reuptake inhibitors, that most commonly prescribed antidepressants, ECT, exercise. Exercise is a really good antidepressant. they all increase BDNF levels, right? And
Yeah.
they all seem, well, particularly with the ECT, the psychedelics, and exercise. I'm pretty convinced from the data on those that there's structural plasticity going on.
Absolutely.
So yeah, actually for me, I got depressed a couple times when I got injured and couldn't exercise.
Yeah.
And for me, I think many people, it's really powerful antidepressant, drug, but it's
Yeah.
probably engaging at least some of the same mechanisms that some of
Yeah,
the drugs.
absolutely. I know that I used to play a lot of badminton. If I got injured, I'd go into withdrawal. I'd be really irritable for days and days and days. We know that exercise is trophic in the brain. We know it has impacts on the GABA system in the brain. I think there's reasonable evidence it has impacts also on the endorphin system. So, and exercise, I think almost certainly turns on the dopamine system because you have to as you're running. So yeah, I mean, it is like a sort of triple acting antidepressant.
And
The big problem with exercise and depression is getting depressed people to exercise.
yeah, yeah, yeah. Well, on the other hand, well, that's the whole big problem with the health. One issue, David, as you know, that healthcare system here, I think UK is not so different, is that there's not much emphasis on risk reduction and prevention, and so people are they get sick and then they're given drugs.
Yep.
There needs to be some mechanism to improve early life general health and habit, exercise.
Oh,
In
totally.
schools now, the kids, when I grew up, and I'm sure when you grew up, every day we had
Yeah.
gym class and we exercised every day we were in school. Now a lot of schools, high school for sure, they don't even have any, it's elective,
Yeah.
so
Well, yeah, I mean, it would be, well, educating kids about health has got to start really at home before they go to school. But it's a
yeah,
problem with the parents if they're not parents aren't healthy. But surely
that's true.
schools should be exactly. I mean, because of it's not just the mood, but it's also the rest of the health, isn't it? The obesity in children
Yeah.
is terrifying now because they're not running around in the playgrounds, they're not exercising. We used to walk to school. We were on the go all the time. Now the kids are driven to school by their parents, they're thrown out. They spend most of if they're not doing lessons, they're on their phones playing games back in front of it's a bit of it's a metabolic time bomb that's building up, isn't it?
Yeah, and that's people get bombarded with advertisements on unhealthy food,
Yeah.
um, and even I got to tell you, even drug ads, they essentially promise, okay, this drug is going to cure your whatever ailment
Yeah.
you have, and so people get the impression that it's okay if they get sick because there's going to be
Yeah, there
something.
will be a solution. Well, yeah, I mean, you're quite right. The prevention is always better than cure. There is no doubt about that. We did something interesting in Britain a few years ago. It was difficult, but we brought in a sugar tax. We taxed high sugar drinks, and to some extent foods as well, more than low sugar ones. Enormous resistance, but it has gone through now, and I think that's beginning to encourage people to at least. Well, it's
Well,
harder to.
I think that the way tobacco problem was approached, it helped a lot for the tobacco problem. And why not do this kind of similar thing to, in other words, they had ads on, we'd see ads, or not ads, but announcements or whatever on television that showing, someone's lung that
Mm,
had cancer,
yeah.
or someone that had a tracheotomy tube put in
Yeah,
because
yeah.
they had throat
Laryngeal.
cancer, but we don't see those ads for obesity,
No,
do we?
we don't. No, we should show people with the heart bunged up with cholesterol. That's right, and the
Yeah, arteries or whatever.
covered in fat. Yeah, no,
But
yeah,
you're right. It's the early life environment and the parents, how what they teach their kids and the habits of the parents, the kids often follow the habits of the parents.
Yeah, because by the time you're old enough to know different, you've got so conditioned to do what everyone else in the family's doing, haven't you?
Yeah, and then you get transgenerational propagation of the
Yeah.
problem.
What's interesting in your country, in the States, though, isn't it? There is also this geographic difference.
Yeah, big one.
Between the two, the coasts tend to be thinner than the middle.
Yeah, and education level disparity too. And yeah, in the South, there's higher incidence of obesity, type 2 diabetes, heart disease, and now, interestingly, even neurodegenerative disorders.
Yeah.
And 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 then, but so it's transgenerational, and so how do you kind of interrupt that cycle of?
Well, it can only be through it. It has to be through sensible taxation, but also education.
Yeah. And you're educating people about drugs. They can go to your drug science website and get a lot of information. I wanted to
Yes.
finish up, David. What was I going to say? Talking a little bit about um, what's going on with clinical trials now of the psychedelics.
Yes. Yeah, well, this has been a very exciting decade. Now there are trials going on in depression, in addiction. I mentioned the smoking one that NIDA's funding, but there's also been a big one in tobacco addiction. There's a big one just published by Michael Bogenschutz in alcohol addiction with psilocybin. We're just starting a trial. We've got government funding for the first time in 10 years to do a psilocybin trial in opiate addiction to see if we can stop people relapsing after they've given up. But there's also interest in other disorders you might not think of as possibly being a target, like OCD, like anorexia, and also pain syndromes. People say, well, what psychedelics to do with pain? Well, the problem with chronic pain is that chronic pain is a kind of an internal loop of neural activity that is pain-centered, but the principle is very similar to that of depression, an internal loop that is centered around negative thoughts, or addiction, an internal loop focusing on addiction. So we're wondering whether we can break those loops with psychedelics, because we know that during the trip, that activity is completely fragmented. We can see that with brain imaging. So maybe we can break the pain loops, and maybe afterwards people will be less likely to slip back into them.
Yeah, I myself have chronic pain issues, but I have it's a rare mutation in a voltage-dependent sodium channel. It's causes a syndrome called primary erythromelalgia, and so it's these particular sodium channels are expressed in the nociceptive neurons, the neurons that convey pain.
Oh, right. Okay.
And there's a guy at Yale, Steve Waxman, who's done a lot of work on these. And so anyway, mine is a gain of function mutation. So my sodium channels opens more easily than most people's. And so then I got into, but exercise is my anti-pain thing.
Yeah.
And that actually helps a lot.
So what do? You run?
I used to run a lot. Now I do bike. I had some injuries and surgeries, so I do stationary bike, I walk, and then I do some resistance stuff.
Okay.
Yeah.
I've not heard of that mutation. It makes perfect sense, doesn't it, though? I mean, does that mean you're cleverer than the rest of us, though, because your brain works faster?
Well, no, I think it's actually maybe a good thing that this sodium channel isn't expressed in the brain.
Is it not?
No.
Oh, wow. How interesting. I didn't know there were that many different sodium channels.
There's a whole literature on this if you're interested, but yeah, Steve Waxman's
an example of what channels do, isn't it, though? It proves the point. Sodium is, that's right. You open those channels, the sodium floods in. Yeah.
Now, you mentioned, so it turns out in the United States, there's a lot of movement to legalize mushrooms for sure, and maybe other psychedelics. And in a couple of places, including Washington, D.C., the District of Columbia, mushrooms have been decriminalized.
Right.
Which they're still officially illegal, but if you have them, you're not going to get arrested and charged. And so there are shops down there you can go and buy.
Are there? I'm coming over in September. I'll go and have a look for a mushroom shop. Okay.
Yeah, and that's very interesting. There's different species of magic mushrooms, and each species there's like a different amount of psilocybin.
That's
So
right.
in these shops, they seem, I guess, this to know through people. I think they're pretty widely used, actually, mushrooms in the United States. And so they can
the big literature on it.
They can tell you, okay, if you buy this species of mushroom, take one mushroom or take two mushrooms or half or something, depending on the
slice. Yeah, it's really critical because there's 100 species of magic mushrooms, and some of them have got an awful lot of psilocybin in.
You can have a bad trip if you take
you
too
can
much.
have a too strong a trip. Exactly. Yeah.
Yeah, and of course there are also places you can go and pay money. Essentially, it takes several days, and you go and they have
on your retreats. Yeah.
Retreat, and then that's in a little safer, nice environment, I guess. But
yeah. I mean, that's also if you can afford it. But a mushroom shop with an educated shopkeeper is a really useful, because that's such a good way of reducing harm. People know what they're taking. And that's also why I think the cannabis shops are so sensible, because they take people, they can educate people, and they get them away from the street stuff, which isn't, in the case of cannabis, is often very strong and often contaminated.
And cannabis is good for pain too.
Have you found that?
Well, I haven't tried it, but maybe I should.
Well, yeah, no, I mean, yeah, I mean, you could even rub it on if there's a particular place in your back.
Well, yeah, it is mainly the feet, but that's interesting.
It's interesting. Okay.
Yeah, it's kind of a neuropathy type thing. So.
Right. It's interesting.
So the neurons, sensory neurons that innervate the feet, they have the longest fibers, right?
Yeah.
Longest
Yeah, they got a long way to go, yeah, especially.
And for I guess a number of reasons, they seem to be affected first, in part because I guess they're so long. So it's an interesting phenomenon.
Yeah, well, the neuropathy starts in the feet almost always, doesn't it? Yeah.
Yeah.
I think the problem is that their nuclei are a long way, and it takes a long time to get all the nutrients.
Well, I thought of using CRISPR. So the idea was to knock out my sodium channel gene. So the idea would be use AAV with a construct to knock out the sodium channel and inject it into the dorsal root ganglion where the cell bodies are.
Yeah.
Now I have a former postdoc that can make the construct for me, the AAV, but what I need is the clinician to inject it.
Yes.
And they seem to be reluctant.
Funny that. I think you might have to go to Mexico for that one.
Yeah. That'd be hard to get through the IRB, I think.
I think you'd struggle. Well, I mean, I think in the end, I think you could get through an IRB, but not for. It's trickier than for the patient. I think if you were doing it for someone else, it would be easier, but for yourself, it's always tricky being your own guinea pig.
But there is a colleague at Hopkins in the medicinal chemistry group he's got my sodium channel mutation expressed in cultured cells, and he's screening drugs.
Okay, cool. Well, look, when you find one, do talk to me about that. I'm fascinated. I mean, to share with you, I mean, I just to share you a little bit more about my history, but when I was an undergraduate, I was actually taught by Hodgkin.
Yeah.
Of Huxley, and I actually had dinner with Huxley.
Yeah.
So I've actually, but I had a course on action potentials taught by Hodgkin. I was a very, very privileged undergraduate.
That was it. So he was putting electrodes in the squid giant axon, right?
Exactly.
These axons are so big you can see them with your eyes and put an
squeeze them out.
electrode.
Yeah.
And
It was a delight.
yeah, exactly. He established how this excitability, the membrane potential, and the sodium. Yeah.
That's right. Yeah, no, it was an honor to be taught by him.
Yeah,
Probably one of the last cases.
I've had a few mentors, not that prominent, but at least in the realms of Alzheimer's disease and neuropathology. So yeah, it's really good to have mentors you admire.
Yes, yeah, and quite. Well, I've been very lucky. Sounds like you have too.
Yeah. Okay, and Saul Snyder, he's retired recently.
Oh, I didn't know you were still alive. That's good news.
Oh yeah.
He's
He still
retired.
had an active
Wow.
lab.
He must be in the 80s. Is he in his 80s?
Oh yeah, he's well into his 80s.
Oh, fantastic. That's inspiration for us to keep going then.
Yeah, and he had contributed a little bit to identifying the opioid receptor.
Well, indeed, and it is said, yes, it's said that he was going to get the Nobel Prize, but
yeah, I know. I was here when that in Baltimore, and everyone was disappointed that he didn't.
Yeah, it
but
was a great.
So many contributions in other areas too. Nitric, gas,
absolutely. Yeah.
Gasotransmitters, the hydrogen sulfide gas, carbon monoxide, and nitric oxide. These gases, which people think of as toxic, carbon monoxide, they're actually being produced by our nerve cells, and they have signaling functions.
It's truly, yeah.
It's amazing.
Yeah, of course, the nitric oxide people did get the Nobel Prize, but poor old Snell didn't. He's rich enough; he doesn't need the money.
Yeah, he's a great guy. Okay, David, I enjoyed meeting you and chatting with you. This podcast has given me the opportunity to get to meet some of the people I've admired in the neuroscience field, maybe in areas a little different than what I was working on, but I think you do the same thing. I like to read a lot of different stuff and have a broad perspective.
Absolutely. Yeah. Well, it's been a great, absolute pleasure to talk to you. And let me know when it's going out and I'll tweet it, all right?
Okay, it'll probably be in about a week or so.
Fabulous. Great to talk to you.
Have a good rest of the spring.
I'm going to go and cook. Cheers.
Okay, bye.
Bye.